Okay, hello everyone. Welcome to this afternoon's virtual hearing. Before we start, can I just ask for a wave from each of you, just so as I can check you can all hear me okay? Okay, that's great, thank you. So my name is David Liddell. I'm the reporter appointed by ministers to determine the appeal reference PPA-240-2065, relating to land at Crownerland Farm at Whitecross. And you've met my colleague Callum, who's also going to be sitting in just to help us out if we have any IT issues. We did have yesterday. Hopefully it will be a little bit better today. If you do lose connection or are struggling with either to see or hear, particularly to hear, then some people yesterday hung up and rejoined, and we were able to deal with that, I think, as best we could. So this is hearing number 6 on it relates to Meadowbank Medical Centre, although it's the third of our hearings to be held. And I'll ask parties to introduce themselves in a moment, but I just need to go through a few formalities first of all. So as perhaps said, for those participating, if you could keep your video on, but turn your sound to mute, except when you're speaking. And for those observing only, please turn both your video and your sound off. So firstly, a reminder that this meeting will be recorded. It will be stored as part of the DPA's webcast archive and will be capable of repeated viewing. I will come back though to NHS Forth Valley in that point before we start. I have the discretion to terminate or suspend filming if, in my opinion, allowing filming to continue would prejudice the proceedings of the meeting. By participating in the virtual meeting, you are consenting to being filmed and to the use and storage of those images and sound recordings and any information pertaining to you contained in them for webcam sharing purposes and for the purposes of keeping historical records and making those records available to the public. And further details can be found in the DPEA privacy policy, which is on our section of the gov.scot website. I see Mr. McLean's in the room, in the same room with a colleague, so it's just to say that I expect relevant social distancing and other COVID-19 related measures to be observed, and if they're not, I may be forced to suspend the meeting. I'm sure they will be. Lastly, I just want to thank you all for the written evidence you've provided to me so far and for agreeing to participate this afternoon, particularly to the representatives from NHS Forth Valley, for helping me with this appeal at a time when so many other demands will have been made on your attention and resources. So, introductions. I see Mr. Campbell there for the appellant. Can you please introduce yourself, Mr. Campbell?
Sir, good afternoon. I'm a Queen's Counsel at the Scottish Bar. I'm instructed by Angela McCracken of Bannatyne, Kirkwood in France, and Mr. Paul Houghton of DM Hall, who is the planning advisor in this case, on behalf of the appellant. In other words, exactly the same as yesterday. With me, I have Mr. Phil McLean of Geddes Consulting and Mr. Alistair Bladowski of the same firm. Principally, I think the answers will come from Mr. McLean, but he is obviously assisted by Mr. Bladowski and may wish to consult him in the course of giving an answer. So you should view them as one. I hope that's enough for the moment, so I don't have any other witnesses in attendance.
That's great, Mr. Campbell. Thank you. And Mr. McLean, I can see you there, but if you just want to introduce yourself just for the benefit of the others.
Good afternoon. Yeah, as John Campbell has said, my name is Phil McLean. I am acting for the appellant, I work for Geddes Consulting, and background in planning and planning applications. My colleague Alistair, who has been involved in the case and reviewing evidence, and he's with me just to provide assistance in terms of the data and information.
Thank you very much, Mr. McLean. I don't know what others heard, but you were a little bit hard to hear now and again. I heard what you said, but just it was a little bit distorted. So just for NHS Forth Valley then, Dr. Herring, good afternoon.
Hi there, good afternoon, everybody. So my name is David Head, and I'm a GP. I work as the GP clinical lead for all the practices in Falkirk, and I also happen to be a GP that works in Meadowbank Health Centre as well. I also advise the GP subcommittee, who's an advisory committee to the Health Board, and I sit on the Integrated Joint Board of Falkirk HSCP. Hi.
Ms. Perry from Buchan and Associates.
Good afternoon, Karen Perry from Buchan and Associates. We are healthcare planners, and I've worked with NHS Forth Valley over the last 2 years on a range of projects. In particular, relevance to this case is the primary care premises review. I'm a qualified accountant, and I've been working in healthcare since 2002.
Thank you very much. Finally, then, Ms. Farquhar, if I'm pronouncing that from the Health Board.
Yes, that's fine, thank you. I'm Morag Farquhar. I am Associate Director of Facilities and Infrastructure with NHS Forth Valley. I have responsibility for estates and capital planning, particularly at the moment around primary care premises and our plans and strategies in that regard. In the room with me is my colleague Brian O'Rourke, who is our Property Services Manager, who has been working in the detail of planning applications and the board's consultation process in that regard. We also have with us Kenny Maguire of Graham and Sibbald, who is our planning consultant.
And finally, for the council, Mr. Vivian.
Yes, hello. My name's Brent Vivian. I'm a Senior Planning Officer at Falkirk Council. I was the case officer that dealt with this planning application, and obviously also dealing with the appeal.
Hi, my name's Alistair Shaw. I'm the Development Plan Coordinator within Development Services at Falkirk Council, responsible for the preparation of the local development plan and associated supplementary planning guidance.
Okay. So thank you, everyone. Hopefully you have seen the agenda for the hearing, which Smira, the case officer, sent out last week. Most of the questions I have are for NHS Forth Valley. I'll try to give other people a fair chance to comment on each of the matters we discuss. If I've not done so, or if you want to come in at a particular point and just raise your hand, or just speak up if I haven't noticed you. I have confirmed that you can ask questions of each other through me, but I'll only allow that to the extent that it will help me understand the evidence before me and the positions of the parties. That's the sole purpose of the hearing. So I have a series of questions to ask. What will be most helpful and time efficient will be if you just answer the question I ask. Sometimes that might be just a yes or a no. There's nothing wrong with that. I've got quite a fair bit to get through, so concise answers will be best. And please remember, I don't need or want any repetition of the material and the written evidence just for the sake of it. But if you do need to go over something so as I can understand it, then that's fine. So I identified in the agenda a number of documents that we might need to refer to. So it might be helpful if you can have these to hand. So for my part, I'm going to be referring to the NHS Forth Valley's hearing statement, the primary care premises report, the floor plans for the health centre provided by NHS Forth Valley, the primary care improvement plan, the NHS Forth Valley's letter to the Council of 16th January 2020 in association with the planning application at that time, I think, perhaps with the appeal, and the Scottish Future Trust guidance on floor space metrics. And I've got all of these opened as PDF documents here, but we'll come to them as we go through the questions. So that brings me to the question of confidentiality. And I imagine this might be a point for you, Ms. Farquhar, but if it's someone else, then that's fine. But so some of the NHS Forth Valley's written evidence has been shared between the parties, but it's not been put on our website for reasons of confidentiality, and that's I think that relates to the premises review and some of the material that is associated with it. So, as I said, I think this is probably for Ms. Farquhar, but do you have an idea as to when the review document is likely to come into the public domain?
It's something that we haven't discussed. I'm aware that obviously if we have questions around freedom of information, we will, and we have shared it. I'm not foreseeing that's an issue, that's now it's included with the papers from the hearing.
Sorry, are you saying that that previous concern about this becoming put in the website or into the public domain, that's gone now, or did I understand?
I think so, yes. I think we can agree to it being included.
That's helpful. What I was going to say is, well, perhaps we might come back to it anyway, but ultimately my decision letter is going to have to treat with some of the issues covered in that document. You know, whether that's the action points, the prospect of one of the practices moving out, or I just want, and I was going to explore with you what the sensitive areas are. But if that's all, if you're comfortable that is going to be in the public domain anyway, then that's fine. It probably resolves that question I had. I suppose you might still feel that we can come back to this at the end of the day, but if some of the discussions we have this afternoon give you concern in terms of confidentiality, then this meeting will be recorded, but for that reason it needn't go on the public website in the same way as the other hearing sessions will be. But perhaps we can come back to that question at the end, and it needn't be something you'd have to answer straight away. You could reflect on it and you could let us know whether or not, from your point of view, what we discussed today is fine for public consumption, if you like. But we can move on for that just now, I think. Okay, so the final thing just I wanted to say before we started is that I didn't ask the appellant to address my questions, only NHS Forth Valley, but I will accept Mr McLean's hearing statement as evidence, that's fine. I note the more fundamental points made there about the tests which need to be made for planning obligations. Without prejudice to those arguments, I think I understand them well enough. What I want to focus on today are some of the more detailed evidence in relation to healthcare infrastructure. But I fully take on board that there is a higher level view from the appellant in terms of the case for levying such contributions at all. Okay, so is everyone content? Understand what we're here to do, and if we can move on to item 1 in my agenda. Okay, thank you. I don't have a follow-up on every question by any means, but I'm just going to using the questions I had and that the NHS Valley answered in their response, just as a template for my questions. I didn't say much about that premise 1, P1, other than it wasn't a good start. It's clearly I misunderstood the position. That's fine in terms of how the catchment areas work. The second part of that, I made the assumption that catchment areas could be adjusted, and NHS Forth Valley's response is that, well, that wouldn't be easy in the current circumstances. But just so I can clarify, I'm assuming it's NHS Forth Valley that runs the health centre and decides how space the air is used and by who, and so effectively it's for NHS Forth Valley to provide the space for each practice. Is that a fair summary of the position?
That's correct.
And get my papers in order. Okay, and my question piece, or my P3 premise, in answering or in responding to NHS Forth Valley said, it's the impact of the proposed development in Parliament Park medical practice and Park Hill medical practice. It's the key consideration and not Meadowbank Health Centre as a whole. I suppose my question is, isn't it the lack of space at the health centre as a whole which is the problem for you? If you could provide more space for these practices at the centre, then you would do.
That's correct. You would, and I think it's important to note as well that the health centre is not just the 3 practices. There are a range of other NHS board services as well as partner services within the building currently, and would be planned in the future. I don't know if Dr. Heron wants to add anything to that about the current position.
Yeah, I don't know, does that answer your question, David? Or
It does for now. I was going to come on. I do have questions about what other facilities are, or what other services, if you like, are run from the centre, because I'm interested in that, and also how that relates to the model facility which is in the premises review. So that's fine. We will come on to that material. Thank you.
okay.
That's it. Sorry, I will try and, Mr. McLean and Mr. Campbell and the council's officials, I will try and look out for you, as I say, interject if you feel you need to, but much of this is factual rather than argument, if you like. So there might not be many of these points you may feel no need to come back on. That's all I wanted to say on agenda item 1. So if we're content, I'll move on to the second one. We'll not get through the others quite so quickly. So P5 was my premise about the size of the floor space of the health centre, and the figure there is 2,070 square metres. That's both floors, not just the ground floor. Is that correct? Yeah. Okay. Okay, and then in P5, the final sentence of NHS Forth Valley's response is that the floor space for Parliament Park medical practice is roughly 200 square metres, and for Park Hill it's about 215. So between them, ignoring shared spaces, they only use about 20% of the health facility floor space, and that, yeah. So I just want to understand what shared spaces do they use, and broadly speaking, how much further floor space in the health centre does that take up?
The calculation that you've got is based on information from a financial basis, so that will include for each practice kind of 3 measures. So what they have solely themselves, what are common spaces and what are shared spaces. They pay the board for the use of all of those spaces, so that will be included within that calculation, and that will include a staff facility and other ancillary spaces.
So just thinking in rough terms, there's a third practice. So if you were to add the 3 together, solely to operate those practices, they only need 30% of this floor space at the health centre, roughly speaking. Is that right?
So, can I just come in there? Yes, that is correct. But the other services that are provided within the building, some of these are key to being able to deliver general practice. So they're not part of the practice's independent contractor position, but you couldn't really have a practice without having some of these other services very close by or within the same building, which is probably why it seems like quite a small percentage of the building use, and quite a large percentage of it is used by health board services. But so these services we're talking about are health visitor services, district nursing services, midwife clinics, health board run treatment rooms, podiatry clinic and physiotherapy facility, as well as some counselling services that are run out of the building, and there's a community pharmacy, and there's some social services rooms. So the majority of these, it's helpful to have them co-located exactly with a practice.
Well, that's very helpful. So, and if you add all of those other services up together, that's what takes up the remaining 70% or so of the building. Is that right? Not directly related to or part of the GP practices. It's just beneficial in terms of delivering the service that they're on the same site. You might have other small practices elsewhere where they aren't co-located, but it's just better to have them co-located, yeah. That's fine. Mr. McLean or Mr. Campbell, I mean, you needn't comment on this point, but if you've got any observations you want to make at this juncture.
I've asked Mr. McLean to intervene if he wants to make any comment on this data as we go through it. So unless I interrupt, I don't think so. Mr. McLean may have something.
Well, just to add, I would agree. We've done our own calculations that the figures that have been quoted do appear to relate only to the consulting rooms and reception areas, and not to include any of the circulation space. I think, and we'll probably come on to it later, one of the issues in the evidence is just an understanding of the timetabling of the other shared spaces. I think that's something that's missing from our point of view.
I may or may not come on to timetabling of other spaces. It probably isn't something I've focused on. So if you think it's important and we don't get to it, then you can let me know at the appropriate time. In question 8, I asked for a couple of other bits of documentation that informed the premises review, because I thought they might be helpful to me. Now that I've seen them, I don't really feel that those two documents take me much further, and that's fine. That's not a problem. It's just that I thought they might have done, and that's why I needed to ask. So I don't feel any need to discuss what's in those documents. And this is just about the floor space of the health centre. So when I look at the ground floor space, NHS Forth Valley said there's 26 consulting rooms. 27 consulting rooms. I consult 25. Sorry, I count 25 rooms which are called consulting rooms on that floor plan. But it's from last year, and it might be that there are other rooms there which really are consulting rooms. They're just not called that in the floor plan. It doesn't really matter. But if I'm told that the right number is 27 currently, then that's fine. There was also a figure of 29 previously, which was based on 29 or I think maybe it was Mr. McLean saying that if there's 29,000 patients and the premises review said there was 1 room per 1,000 patients, then that would be 29 consulting rooms. But so I just want to clarify from someone from NHS Forth Valley, it's the number's 27. That's right.
It is. The Pullman practice currently has additional access to a further consulting room, which is the difference between, I think it was 26 and the 27. I think it's important to note, though, as well, that the current space will have been based on different guidance. We're working with a building that was designed some time ago, whereas in our look forward, we're using more up-to-date guidance, and that will drive a different number.
That's just one of those other rooms in that floor plan is now acting as a consulting room. Is that?
Yeah, you're absolutely right. So the number you counted is the right number that were supposed to be consulting rooms, but because of space issues, we've converted some of the other rooms that was for a manager or for other administrative things into consulting rooms to try and manage the requirements.
Can I just ask a clarification if a room denoted as a practice nurse room should be regarded as a consulting room? In terms of where it is on the drawing, I'm not sure what the north point is, but it's in the top left of the ground floor.
It will be, in terms of that will be a room where patients are consulted with, but it won't be a GP consulting room as such.
Thank you for that. We will come back to this issue of what the different rooms are used for and the model in the improvement plan and how that changes, if you like, from previously what a consulting room was and who's using it. I am interested in that, which maybe where Mr. McLean was starting to go with that question. But if we can park that issue just for the moment. That takes me on to the third part of the agenda, which is about the primary care improvement plan. And I don't have any follow-ups to P11 or P12, or 13, in fact. We will come back to some of the issues that might be raised in these questions later on. Yeah, if we can focus on question 15 then. So I asked there how many consulting rooms there were in the example schedule for a large centre from Appendix E from the premises review. So if you're able to, we're able to have a look at that kind of model floor plan at Appendix E. Sorry, no, it's not a floor plan, it's a schedule of accommodation, isn't it? That's at page, well, I have a PDF and it's at page 35, 38 PDF. I'm not going to go through it in forensic detail, but I'm just trying to understand a couple of things around it. So it's provided as an example, and you're indicating to me that it's got 25 consulting rooms for GP services for a population of 25,000, and the range given in the document is for this facility is 15 to 25,000. It seemed to me that the example given so that's the orange example at the far end of the table, albeit the range is 15 to 25,000, and that example seems to be at the top end of the range, because if you're having a kind of assumption roughly of one consulting room per 1,000 population, that's got 25 consulting rooms. It seems to me that that's at the top end of that scale, that example. Is that fair enough?
Yeah, that's a fair recollection of it. Yes, it is being calculated at the top end.
This takes me back to the clarification you provided for me about floor space and this idea that the existing practices take up 30%, these other services take up 70% at Meadowbank. So the question I was going to ask is Meadowbank hosting any functions now which are not in this model example, in the orange example? What's the position there?
David will correct me if I miss any, but certainly social work isn't in the example, and social work is clearly within Meadowbank. So there were, largely speaking, the services are fairly similar in terms of the scope of services. So we talked about podiatry, physio, but not everything that's in the examples in Meadowbank, and also there are some additional services in Meadowbank. Pharmacy is another one. Pharmacy isn't in the standard schedule, but clearly there's a pharmacy footprint within the Meadowbank Centre.
I think the physiotherapy, the large area for physiotherapy is not practice physiotherapy. That's health board physiotherapy, which sees patients from round about this area in that building. So that's not, I don't think, included.
And if I get the figures a little bit wrong here and there, it's okay. But of that 70%, most of it is accounted for, as you would expect most of those services from the 70% in Meadowbank to be accommodated in this kind of service. But there's a few exceptions to that in relation to social work, pharmacy, and physiotherapy. Those you might not expect them to be provided in the model example. So I just want to understand that this model says there are 25 consulting rooms. I just want to understand what ones those are. Looking through that table, the first part of it is patient interface. The first 7 or 8 rows, and it seems that there are GP stroke nurse consulting stroke examination rooms. There's 23 of those, so I assume those are, when you tell me there's 25 consulting rooms in that example, I'm assuming that those 23 are part of that 25. And there's another 2 GP brackets training consulting room. So are those the ones which make up the 25?
I certainly believe so, Karen.
Sorry, I was just going through it. Yes, I mean, I think in the example that's in there also splits out to see the different elements of service, from board provided services to GP services, and clearly it was deemed as an example. It was never meant to be for any particular one. It was to give a size and scale of small, medium and large, and the relative types of size of space you were looking at for those types of ones. It was never designed for any particular practice in mind.
Well, that's right. Apologies for the detailed nature of these questions. I'm just trying to understand. So, in addition to those 25, there are under board services. There's interview rooms, which is 7. There's consulting rooms, which is 10. There's a few others. From what I've heard earlier, these are the kind of rooms that make up currently at Meadowbank that other 70%. Yeah, they're non-GP. Yeah.
Yep, absolutely.
NHS the developer contribution, which NHS Forth Valley would be seeking, is only towards the cost, providing the 30%, if you like, for the GP practices, not the 70% of other facilities that go along with it, or is it both?
It's contribution to healthcare services in general.
So let's assume it was felt that the housing development meant a need for 30 square metres of GP floor space. Yeah. Would the contribution be to provide that 30? Because that's only this floor space used by the practices, or would the contribution be to provide the 100 square metres, because that's the totality of what the health centre is providing? I'm just trying to understand which of those two it is.
It would be the totality.
Press ahead, but interject if you feel you need to. But I will give you the chance to come back if this ultimately, if you get comments to make on this anyway. But do interject if something's pressing. Probably ask people to be concise. They don't really listen, but actually we're doing quite well so far. So I'm grateful for the responses. Okay, so just moving on to 16, and some of these questions that I've got, we might follow you because I've got answers now. Yes, Appendix C provided as an example. We've said that it's got 25 consulting rooms for 17 GPs, full-time equivalent GPs. That's what the model's got? So that's roughly consulting rooms, 52 full-time equivalent GPs, because those rooms are also used by other clinical staff.
I was thinking Karen was going to come in there.
So I was getting to the relevant part. So there's 17 GPs plus also advanced nurse practitioners, which are a new role as part of, I guess there's two types of advanced nurse practitioner you can get. A GP practice as an independent body can employ an advanced nurse practitioner if they're maybe struggling to get GPs. But in addition, NHS Forth Valley, as a number of boards have to implement the primary care improvement plan, have employed a direct number of advanced nurse practitioners to deal with urgent care. It's a different way. So the majority of practices now will have advanced nurse practitioners. So the numbers include space for those as well as GPs.
We'll come back to some of this kind of material towards the end anyway. Thank you. Number 4 in the agenda, which is the primary care services and premises review. There's an overlap here in some of these questions. in answer to my question, you say that the ratio for GPs is 1 to 1,500, 1 GP for every 1,500 population. I couldn't find in the documentation where this is set out and the basis explained for it. I can't see anything in the improvement plan or the Prime Minister's review that gives that number, so I'm just wondering where it comes from.
No, in terms of where that number comes from, following on from Premises Review, we've worked with both Stirling and Falkirk councils to review the supplementary guidance and to look at rates per 1,000 for GPs. I guess primary care improvement plan was about everybody else as part of the multidisciplinary team in primary care except the GP. It was looking at all the other roles that are required to support it. So that's why it's not in the primary care improvement plan, and therefore then why we weren't looking at it as part of the Premises Review. However, when we then turned to look at revising supplementary guidance to take into account the overall multidisciplinary team that is in primary care now, that was when we wanted to review and work out what's an appropriate rate for GPs. To do that, I worked closely with Dr Stuart Cumming, who at that time was the Associate Medical Director for Primary Care Services across Forth Valley, and we agreed that rate to take into account a number of things. I'll go over those. One was, and I think currently the ratio can be anywhere between 1,600, 1,700. It will vary practice by practice. The current Polmont practice, I think, is 1,800, so it's very much up at the top end. And particularly one of the reasons that we're bringing it down was to look at things like patients who will present themselves in primary care will have increased comorbidities, multiple diseases, and much more likely to require multiple consultations and also longer consultations. In addition, when we look at the demographic profile, particularly within Falkirk, and the number of aged over 75s, they increase by 66% between 2016 and 2036, looking at the latest GROS population projections. Clearly, they place a much greater demand on GP time, and the ratio doesn't take into account individual needs. So as we have an ageing population, it's much more likely that they will become much more reliant on GP services than your sort of atypical population. And the last point was to take into account and to mitigate as far as possible against GP sustainability issues, which has been fairly well documented in terms of GP burnout and some of the difficulties to recruit and to retain GPs with list sizes considerably higher than what's manageable. So taking all those factors into account, that was where Stuart and I agreed on the rate of 1,500 in terms of moving forward.
Can I please just come in on the point about the current ratio at Polmont Park, because the figure quoted just there of 1 to 1,000 doesn't seem to support the case that's being made, in the sense of what is it that means that a GP can't actually in Polmont Park support a higher number of patients? I'm struggling to understand that.
Yeah. Do you want me to come in and answer that, David? So I'm not sure what the data is you've got for Polmont Park. Polmont Park have just over 4 full-time equivalent GPs, and we've got 7,000, almost 7,500 patients. I'm not quite sure in the maths, but I think that would work out about 1,850 per full-time equivalent GP. Potentially, there are 6 GPs that fulfil the 4 full-time equivalent positions. And there's also it's a training practice, so they have trainee GPs, but trainee GPs they're supernumerary. They don't actually provide any dent on workload, as you can imagine, because they're in training, they're not fully qualified GPs.
Mr. McLean, I thought about whether I would ask you this and I decided not to, but I wondered whether you've given me evidence about the numbers of GPs at the various practices. I wondered whether you were assuming they were all full-time, whereas in reality they weren't. Is that what the difference is, Mr. McLean, perhaps? Have you assumed they're all full-time?
What I think it would be useful to look at is the timetabling information that formed part of the NHS response, because that's something that we've looked at in some detail just to understand actually what's going on. And you know, there's a spreadsheet of it, but to summarise what it's telling us, there are 10 rooms, consulting rooms, as we've talked about already, and they're in slots in the morning and the afternoon. So the combined total of the 10 rooms and 5 hours morning, 5 hours evening, slots across the day, there's 500 consulting hours across that. If you look at what's actually timetabled in across that 500 hours, there's quite a number of free slots, which amounts to over 10% of the total hours. And the timetabling information notes doctors 1 to 11, although one of the roles that's noted doesn't have any hours against it. The timetabling also covers off registrars, trainees, but if you add up the slots that this timetabling information says are occupied by GPs, it comes to around 287.5 hours, and that, assuming a 37.5-hour week, is about 7.7 full-time equivalent GPs. So I'm struggling I realise that some of the information is at slightly different points in time and things are not completely static, but I'm just struggling to understand the completely different numbers that have been quoted for what are the actual staff employed at the practice.
Yeah, so obviously to suggest a doctor who's doing a session from 8 till 1 actually goes home at 1 o'clock is probably unrealistic. Although and full-time GPs would a full-time GP would consider 8 sessions, which is 8 times 5 hours. But we can't actually use their room for someone else at exactly their finish time, because the GPs very rarely actually finish at that finish time. Because of the workload, we tend to go on a bit longer, so you might see a little bit of blocking because of that. That's real. That's patients being seen. The data for the room use that you're seeing has labelled doctor 9, 10, and 11. It's been anonymised from what was actually there, and in actual fact, the doctor 11, I think, is a mental health nurse in actual fact. Doctor 10, I believe, is an advanced physio practitioner. These are all people that need a room. I think it's just when it was anonymised, it's just been marked as a clinical room. So this practice has 30, well, at the time of this, 34 sessions of GPs working in it, which you can mark off 34 sessions in there. And at the time of this, it was, I think, 2.5 trainees, which is the registrar and the trainee room use, or I think it was 3 actually, full-time equivalent. As well as I said, the advanced physio practitioner, the mental health nurse, and that's accounting for all that room use. So it's not actually all GP time.
That's helpful in terms of where I was asking. I suppose if I could just make a comment that ultimately, if rooms are being used by other professionals, it strikes me that is part of what the primary care improvement plan is about. And ultimately, I think, from my point of view, we need to keep in mind in terms of the purpose of actually why we're here today. It's less about who's delivering what care, and it's about what physical space requirements are there. So whether it's a GP or some other practitioner in the room, the key thing is suppose the key message that I take from the timetabling is actually that there's a number of free slots, over 10%, and so I'm still not clear why there is a need for further physical expansion.
Right, I don't see these free slots on the timetable. I can see there's a few times when it's free after 3 p.m. A free room after 3 p.m. I don't know if you've ever tried to employ people to work from 3 p.m. till 6 p.m, but it's very tricky. There is a very small number of rooms that are completely free, but this is just an example of the room use at that particular point in time to deliver GMS services as it was at that time. And you can see, I didn't count 10%. I can see, if you don't count the free after 3 p.m, because as I said, trying to employ someone for that would be very tricky. But the other free slots, I can see four free slots out of 50. Is that right?
Dr. Hen, can I come in at this point? I just, for two reasons. People were flashing on and off on my screen. Can people just give me a wave if they can hear me still? Okay, good, thank you. I just want to make an observation. I didn't pay too much attention to that timetabling data, partly because it's difficult to interrogate, you know, from afar unless you know much more about what it's telling you. But B, or secondly anyway, it said it was a snapshot at a point in time. And I suppose the other point I'll make, and I'm not making a finding of fact here, Mr. McLean, but it seems to me that NHS Portfolio has gone to trouble of doing a premises review and has given me a lot of data and personal experience here about why Meadowbank is pretty full and would need to be expanded. I'm not enticed by the idea of trying to unpick how it programs its space to demonstrate that. I'm finding myself convinced at this point of the point that the centre probably needs to be expanded to accommodate more patients or more services. What I'm more interested in is what that means for the case for any development contribution from this development. I'm more interested in that side of it as to whether, as you identify, whether the tests apply, whether you can meet, whether you can quantify what you need to do, how much it's going to cost, when you're going to do it. Those are areas I want to get into, and I'm not saying I'm reaching a settled view in that, but I don't think having a more detailed discussion of timetabling of rooms within the centre and trying to second guess how NHS Forth Valley does that is going to take me anywhere. Go back a bit then. A few. There's Mr. Campbell coming back. Just pause a second. Mr. Campbell, did you miss some of that?
Sorry, I had to do something which I didn't want to broadcast all over the internet, so I was listening, but I wasn't visible. I was here all the time.
Okay, that's fine. So, Ms. Pirrie, you were explaining where the 1500 ratio comes from, and you explained the process that you went through with a doctor to derive that. That's fine. That's not written down somewhere in NHS Forth Valley's standards or targets. I'm not saying it needs to be, but I just want to clarify that it isn't. Is that right?
It's not letting me. Sorry, it wasn't letting me unmute for a minute there, but I think I just lost connection. As I said, it wasn't in the premises report. Where we did work up was as part of the draft, but I appreciate it as draft supplementary guidance that we've been working with both Falkirk and Stirling Council on.
expectation is that in due course it would feature in that draft supplementary guide.
Correct.
So, I wondered whether it was in. I may be wrong about this, and Mr. McLean might be able to tell me what the right answer was. I thought I saw that number of 1 for 1,500 previously, before the improvement plan came into being, and so my question was going to be, well, if it was 1,500 before, and the improvement plan is based on a premise of freeing up GP time and utilising other professionals, wouldn't you expect that number to go down from 1,500? Maybe not, because you also talked about an ageing population. You talked about other reasons why it would need to go up. So I'm just trying to understand, has it always been 1,500, but it still needs to be because of these things? I'm just trying to understand the evidence around that. And so, Dr. Hearn, I think you're going to tell me, but and if Mr. McLean wants to come in after that, that's fine. Sorry, carry on.
Yeah, just the premise of the primary care improvement plan was to reduce the workload of GPs, but not actually to reduce our clinical time. So it was to allow us to spend longer with individual patients, but not to consult less. So I think the ratio would be exactly the same. It was more about reducing the kind of stress and the fast pace, rather than actually reducing the amount of clinical time. So I think the 1,500, as it was previously, and it always has been around 1,500 in Scotland, has been a kind of accepted ratio, would remain.
You can comment, but if you've got a comment to make, then I'll give you the chance now.
I'm not completely following the logic that if GP time is being freed up and that a lot of cases of a particular nature are being dealt with by other professionals, that doesn't mean that the number of patients that a GP can accommodate isn't actually increased. I'm not following the logic of that. I think the point is that the GPs, as I understand it, are then focusing on particular patients with particular needs, and that some of the other patients that have lesser needs or different needs that can be dealt with by others don't need to see the GP on a normal basis. So the ratio would be expected to increase. I think the other point I would just want to raise is that our understanding, the whole purpose of the primary care improvement plan, the NHS on a national level doesn't actually support the use of these ratios. And so this is why our evidence has been focused on trying to actually understand the utilisation of space in the building if there is an impact from implementation of the primary care improvement plan, which is not an impact from development, and then to understand if there is any impact of development over and above that, that actually takes it beyond the physical capacity it has at the moment.
So I wonder if I could ask Mr. McLean just to slow down a little bit, recognising that you have to take notes. If you don't mind, Phil, thank you.
Yeah, sure. I mean, I think I've probably come to the end of that point, but happy to elaborate further or repeat any of that if needed.
Yeah, I mean, I think I understand. Maybe not necessarily something for Dr. Bell to comment on. I understand the distinction you draw there between the effects of the improvement plan, and on top of that, what other additional effects you might have as a result of new housing development. And that comes through in your written submissions. At what I understood Dr. Bell to be saying, the first point you make is that freeing up GP time doesn't mean that he was saying doesn't mean that therefore the ratio can increase, because there's too much pressure. Well, it allows GPs, for those patients they do, to spend more time with each patient and provide a higher level of care. And and therefore that balances up the effect of bringing in the other healthcare professionals. I haven't thought about whether that makes sense to me or not, but that was his explanation, I think. Is that right, Dr. Heron?
Yeah, that's exactly it. Remember that the 1 per 1,500 is by list size. So although I might not be seeing as many patients, I'll still be looking after the same list size, but I'll be able to spend 20 minutes or half an hour or 40 minutes with one patient because I've got other people who can see the 2 or 3 patients in that time that I should have seen as well as that person. So the ratio, I think, still seems the same. I'm maybe not explaining it perfectly, but
No, that's fine, thank you. It's 2 o'clock. I wasn't planning to have a break. I think we're doing quite well. It hopefully won't take the full 2 hours. Are people happy just to press on just now? I know some are doing more work than others. I don't mean me. I mean you. So if we're happy, then I just want to move on a little bit. Thank you, Mr. Campbell. Right, bear with me. Okay, yeah, some of the questions, some of the material that I asked about in 18 and 19, but we naturally come back to towards the end. So yeah, questions 22 to 24 were all about a number of actions that the Premier's review recommended to be done short term or immediate and short and medium term. And they haven't been done because of coronavirus, so there's nothing at all surprising in that answer. I wondered whether Mr. McLean had any comment about that in terms of what that might mean for the case for a contribution.
Thank you. Yeah, without, as you've alluded to earlier, we've set out in the written submissions what we understand to be the necessary tests and the impact assessment method. So I won't waste time by going back through that, but I think our fundamental point is that if there is to be a contribution, it needs to be based on specific mitigation measure, and it needs to be understood what is that measure. Is it, for example, 2 consulting rooms? Is it other space? What is the floor space required? I'm not clear from the written evidence. There seems to be conflicting views on whether it's feasible to expand the practice. I think I understand that a new medical service is not a solution that is being promoted, but there's also a suggestion of moving certain facilities out of the building, presumably facilities that don't need to be based there to provide medical care. And if that were to be a solution, it's not clear what these services would be. Would they be going somewhere that there is capacity to accommodate them? Is there actually a physical infrastructure requirement arising? So I think the key point is to need to define what is it that's actually needed. And in the context of my earlier comment about the need to separate out any actions that are a consequence from the implementation of the improvement plan, separating those out from any other actions that may be required as a consequence of new development, or at least separating out in a proportionate sense what the respective impact would be. I see John waving.
That's fine. I was just, Mr. Campbell, sorry, carry on.
It was quite a long answer. Did you get all of that, sir?
So, yes,
I think that's a yes, is it?
Yeah, I think I did. I'm not surprised by those comments. I imagined Mr. McLean would make comments like that. That's fine. It's consistent with the earlier evidence. It's why I gave him the chance to answer. I'm also hopefully that we'll have a recording of this. So if I don't get every word, then I can go back and get it later. That's fine. I don't necessarily need a response to that from NHS Forth Valley, but if you want to give me one, then I'm going to give you that opportunity, Ms. Perry.
Thank you. I guess it was really to say that the purpose of the premises review looked into what was required to implement primary care improvement plan in the first instance, and what that demonstrated from a Meadowbank perspective was that all of the space was required in the first instance. Then the secondary part of the primary care premises was then to start to look at the impact of housing after taking into account. So there was a clear first stage take into account the first thing we know that's happening, because clearly housing can change, and obviously different things happen depending on the time you look at it. So for me, it'd be fair to say that the premises report really looked at the impact of PCIP, the improvement plan, what was then needed, and that was demonstrating where work was then required, and then anything over and above that would then be looked at as part of, I guess, what we're looking at now.
And just, I will come back, Mr. McLean, you made a couple of questions there. You made a couple of points about the feasibility of extending Meadowbank, and I'm going to come back and touch upon that question in a moment. But that's fine from now. Thank you. Question 25 was about this, and in the last sentence of the NHS Forth Valley's answers ended, it's unlikely that any further configuration would free up any additional space within the building of GP practices. So the immediate action was to, the short term, I think the short term and medium action was to look to see if you could redistribute space within the centre to free up a bit of space. Now, I appreciate that's not been done because of coronavirus. Feeling is that even if you can squeeze a bit more out of the facility, that will help. That would be help, but it's still going to be likely to be. You'll still likely need to extend it as a result of the improvement plan alone. That's.
Yes, we're clear from our assessments, and Dr. Hearns alluded to it as we've gone through in terms of capacity and the other services that are within there. We are currently planning some internal configuration for the other practice who's not affected by this particular development, but that is just that is a merged practice, so that's just about their patient flow and their administrative space. It doesn't give them any further clinical space. The only way that we can see of providing extra clinical space for the practice, or indeed any other associated service, is about that its extension or its relocation of services elsewhere.
So, question 26 then, you mentioned there the prospects either of extending Meadowbank or to a new location, or moving part of the services there to a new location, and that's what I asked about in 26. And in responding, you're saying that if you were to move one of the practices, you have to do an options appraisal, and prepare a business case, and that's not been done. Would you have to go through the same process for extending Meadowbank?
We have our governance, and much of it, depending on what process you go down, depends on the value of the work. But we would need to be testing the feasibility of this, both in terms of the site, which is constrained, very much so in terms of what we currently have, and the neighbouring facility. and then looking at any other available sites, or indeed if our own premises, if any of other neighbouring locations have any capacity within them.
Whether you're extending Meadowbank or moving part of the services out, there's a governance and there's certain procedures to go through, which are what you would expect. So that's not particularly a constraint then to moving out. You're just saying that you would have to go through that process.
Yes.
And then you go on to talk about the informal feedback from the practices at Meadowbank is that the moving out partial isn't really a preferred option. So again, caveated by the fact that you haven't been able to progress the premises review in the way that you wanted to. If you were offering a view now, it's the most likely outcome is a desire to increase the capacity at Meadowbank rather than to move part of the services out.
I think that's certainly the view of the practices. I can see Dr. Herron's nodding there.
I mean, I think informally that is the view of the practice. I guess if you would really want to go through a proper options appraisal though and make sure that everybody's aware of what the different options are before you fully settled for that. As Morag said, the site at Meadowbank is very constrained, and so it's hard to imagine what extension could be done within the site. But there is advantages to us co-locating that the GP and the practices can all see as great advantages to being in the same building.
So I was going to ask about that constraint because if you read the committee report for the planning application, the council's planning officials, presumably having talked to NHS Forth Valley, or were saying their understanding was that the site in Meadowbank was constrained and couldn't be expanded because of that. But it sounds like you say, well, it's tight. You might be able to extend, but that would depend on feasibility. And so you might do that. You might do something else entirely. Okay, just Mr. McLean, it's not necessarily you don't necessarily feel you have to come in, but I'm just saying I still keep in mind the points you made there about your view that you need certainty. You need to know in order to levy a contribution. You need to know what you're going to do, how much it's going to cost, how much of it you can ascribe to the development in question. So just to say you don't need to repeat all that again in response to what you've just heard, because
yeah, that's fine if that has been understood. Yep.
that takes me on to item 5, which is floor space metrics. So just a few detailed questions I have about some of that material. So my question 29, so I'm just going to pick up some of the answers that the NHS Forth Valley gave me, just because that just kind of feeds into the questions I have. So this is at 29. So confirming there that a small room can be used for pharmacy and for primary care mental health nurse. Pharmacist role would only be 25% patient facing, so that affects the amount of space that a full-time equivalent needs. That's helpful. I wonder what it means for the amount of floor space required, and presumably that's less than if you're basing it on the SFT metric, which is based on a single size of consulting room. But we'll come back to that in a moment. Under question 30, I'm asking about it was if it was the council had raised this point as well. There's a range of floor space kind of options in the Scottish Futures Trust guidance, and so it's more efficient to have a big facility than a small facility. I think the council and I was wondering as well if you're extending Meadowbank, wouldn't you benefit from the economies of a larger scale? And the answer is it wouldn't, because sorry, let me get this right. Because it's an expansion rather than a full development, you wouldn't get the same economies of scale. But I just wondered about that, because if you're adding, let's say, new consulting rooms on to an existing facility which already has a reception area, staff room, plant room, these kind of things, it just seems to me more obvious that you are benefiting from that existing economy of scale. We're not talking about in terms of build cost per square metre, but the amount of new floor space required. You're not having to provide the same kinds of reception areas, staff room, etc., which is already there. So I would have expected you to be at the more efficient end of that range rather than the lower end of that range. So I'm just wondering what the basis is for taking the opposite view.
And I guess the premise of taking that lower range was to follow the logic through, and that we were only purely trying to look at the change that was required directly as a result of the housing and treating that part separate. And therefore then there is a diseconomy of scale because you're only looking at a very small part of it. And the way the SFT guidance is there, there isn't anything that's there for just extending. So we're trying to use, I guess, information that's all referenced and available to then match in together.
I think that's an important point. We were very much trying to use something that was evidence-based, and the SFT metric is something that's been there for some time, and possibly will be being reviewed in the future. It's based on the older service model rather than the what we're working with now in terms of the improvement plan, etc.
An observation on that.
Yeah, if I could come in, and I think there was a comment made a moment ago separating out floor space metric from cost metric, which I think is absolutely fundamental. I think possibly the comment about economy of scale may or may not have some relevance to a cost metric, but that's not really the issue that we're talking about here. In terms of floor space metric, I think the appropriate comparison would be with relevant examples, and it's not something that we've introduced previously in written evidence, but I am aware, for example, in the Falkirk Council area of an extension to Bo'ness Health Centre for 3 consulting rooms, which was 83 square metres. So I think to have ratios of 100 to 160 per GP, which are derived from looking at a new facility, is just not relevant to considering extension when the ancillary facilities are already there.
I've not noted down that figure just because it's new evidence, but I take the general point. I think that's probably something I'm just going to have to take a view on. Whether or not in the end it's a very important point, I don't know, but I'll think about that point.
Yeah, David, can I just comment on that as well?
Of course.
I wasn't sure what you were saying there, but it sounded like you were saying if you add on a couple of consulting rooms, you also don't need to increase the size of the admin area and the staff rooms and such. But my thought would be that for every GP that you have, you actually do need admins. You need all the ancillary staff, and they need additional space as well. Obviously, you said you're not taking the evidence from Bo'ness, because I don't think I can comment on that. I couldn't comment on whether that increased clinical room has put huge undue stress on the administrative areas and the staff rooms that wasn't accounted for. I really don't know. But clearly I would look to increase my admin staff and my ancillary staff as well as the consulting room.
Yeah, but the bonus project is a new one, surely, and it's just been constructed, I think. Is that right, Mr. McLean?
I think that the key point would be to, if there is to be suggested that there is a need for more admin or any other type of ancillary space, the underpinning of that would need to be that the current amount of that space is insufficient for the increased floor space, the increased capacity, the increased staff numbers. So the two go hand in hand in that sense.
Thank you. Yeah, no, that's fine. I think I understand where people are coming from. Dr. Hearn, if I what I wasn't, the premise of my question wasn't that all you need to do is bolt on consulting rooms. I think I would assume that if you are adding in new consulting room, you have to think about, do we have enough ancillary and other accommodation to go along with it? It wasn't as stark as that, but I think what I was speculating on is if you already have a facility, you have already got some big, expensive, but already paid for parts there already, and so like a plant room, like a big staff room. So you might need to extend some rooms, but you don't have the big upfront costs that you do have in a new build facility, and therefore, in terms of additional floor space that goes along with the consulting rooms, I would be expecting when all you're doing is extending an existing large facility, it just seemed to me that the metric which most obviously jumps out is the one for the large facility, not for the small facility, when we talk about floor space. So that was the premise of my question. But I can take that away and think about that point. Question one. So it's just this, I think there was a slight typo in the response I got to that, and you might have noted it already. I just want to check it's right. So it says the combined ratio for patient is calculated at 1.07 rooms. That's 1.07 WTE, isn't it?
Yes, it should be, yeah. And then the rooms is the subsequent column. Yeah.
Sorry, I lost you all for a minute there. Because I didn't hear this. Can you give me a way first of all, just to make sure you can hear me just now? Okay, thank you. Yeah, the response to 31, it says that the combined overall ratio is 1.07 rooms per 1,000 population, but it's 1.07 WTE per population and 0.92 rooms per population. Yeah, that's correct. That's just a typo.
That's correct. Apologies.
No, it's quite clear. Just and based on the earlier answers, some of these might be in smaller rooms. So pharmacy and mental health nurse, they would use a smaller room. Yeah.
I suppose they could use a smaller room. It takes away future flexibility if you put them in a smaller room from the beginning. And we do need to take into account the different types of patient groups that they will see, but it doesn't need as big a space as the other ones.
Yeah, I think most of the rooms in the health centre are around 14 or 15 square metres, which to see any patient face to face is not a huge amount of space. A mental health patient with anxiety or some difficult mental health disorder, to try and see them in a smaller space might actually not really be practical. Quite tricky to do, so I'm not sure about the smaller size rooms for these people if it really works.
So you could in some circumstances use a smaller room. You might not necessarily build all such rooms in that way because there's a flexibility issue. Okay, I will, if you want to come in, Mr. McLean, give you a chance to. I just wanted another one I wanted to ask you though first. So the appellant made the point that in the improvement plan, the pharmacy has a range of 1 WTE between 5 and 10,000, and in the calculations here, you're going for 5,000, so to one end of that scale. And I suppose the question was why. So on their behalf, I might as well ask it.
So within the improvement plan, we have recruited to 1 per 5,000. I'm not sure why it said 5 to 10. I think that, remember, the improvement plan was written for GPs and GP practices and for the Scottish Government, and I think that was in a hope to not get people's hopes and ambitions up too much. But we have managed to recruit to a ratio of 1 to 5,000.
That's the target ratio that the health board is adopting across the area, yeah. Okay, Mr. McLean, I'll give you the chance. Well, I'll let you come in now. I've got a few other. If there's anything you want to say now, then that's fine. But I am going to come on to talk a little bit more about how that answer there to 31 impacts upon the floor space and the metrics and stuff. But is there anything that is burning that you want to say now?
I think there's 2 points I would raise. One of them might be the point you're about to come on to. But just an observation that in the breakdown of items there, a couple of those things are what I understand of the evidence and what we've talked about earlier. These are things that might be provided in the NHS hub spaces rather than necessarily within the area of the building that's for the practices. So I'm specifically meaning pharmacy and physio. And then I have one other point, which may be what you're about to come on to. I'll just pause to let you take a note. Which was really just if you then apply the figures, the 0.92 rooms per 1,000 population, you apply that to the current patient list at Holman Park, which is around 7,500. That gives you a figure of 7 rooms. And so again, just on quite a fundamental basis, I'm struggling to understand the argument that the 10 rooms that are currently in use are not sufficient, and therefore that more physical capacity is needed. I just cannot follow the logic of that at all.
So 0.92 would give you a need for 7 rooms at Holman Park. There's 10 rooms there just now. Therefore, why do you need any more? No, I wasn't going to ask that. You're doing more arithmetic than I am, but I'm going to give the chance for NHS Forth Valley to respond to it.
Yeah, on the first point, the pharmacy and the physio services. So the pharmacy, the community pharmacy that's in the building is a quite different service to the pharmacotherapy service that's being delivered in practices. It does 2 completely different roles. And likewise, the physio, so the physiotherapy area of the NHS part of the premises delivers a completely different role to what the advanced physio practitioners within practices delivered. Professionals, both from pharmacy and physio, trained in slightly different ways to do totally different roles. The 0.92, I'd probably let Karen answer the 0.92.
Thank you. I think it goes back to there are a number of other clinicians other than just we've looked at there. So that point 92 doesn't take into account practice nurses who an individual practice would choose to have. Also, we talked earlier about the fact that they're a training practice and there are 2 supernumerary clinicians. So there's already 3, but there may be other types of services that aren't purely within that calculation there, that are all determinant on an individual practice and who they choose to have as part of their team.
Yeah, a phlebotomist I would add to that as well, actually.
Is it possible, just on the latter point about the phlebotomy, just to get a better understanding of what their space requirements are? My understanding is that the majority of their role is out in the community rather than in the building, but I'm not clear on what the space is that they would need.
Yeah, I would probably estimate about 95% of phlebotomy takes place in the building. Our phlebotomist works out a much smaller room than the rest of the clinicians. And in my practice, we have 0.8 of a phlebotomist. The other 2 practices in the building have, we've got 1 whole-time equivalent phlebotomist, and the other 2 practices have 1.5 between them. So these are people that work through the day, seeing people in the building to take blood pressures and take blood.
Okay, thank you. I just want to come back on that, the second of those points there, because and I may be just misunderstanding this, but I thought that a large part of the case for NHS Forth Valley is that you're deriving these metrics which are based on the primary care plan or the improvement plan and then the premises review, and you're coming up, that gives you a figure of 0.92 there for rooms per 1,000, and so that's what a contribution might be based on, or how you would calculate a contribution, or the kind of how you would it would provide a metric on what you would use for a contribution. But if you compare that metric to what's existing in the practices, it turns out there's more space than that might indicate is required. So then you said, but there's other clinicians as well, or other staff that you had to factor in. I thought the whole point of the metric was to factor in everything. And what's the use of the metric if you then say it doesn't tell the full picture because you have to think of these other stuff? So how does it help me at all?
I suppose the other ones to say is they're ones that are directly driven by population, whereas the fact of a practice has got trainees or not isn't driven by population because they are supernumerary. So you wouldn't want to be asking for contributions for space for trainees, if that makes sense. So they're already in there and they're part of that and using that existing space, and because of that supernumerary role. I suppose the other ones that we talked about were phlebotomy and practice nurse. I guess you could go further. There isn't a evidence-based metric that we could use. So what we were trying to do was to put in metrics that we could find and we could source. But accepting that there are maybe other wider members of the multidisciplinary team within primary care that aren't all in there. Some of them may need to require to flex up as there are additional roles. But there is also that other component, as I say, in terms of the trainees, which are purely down to the individual clinicians within the practice and whether or not they're a trained practice or not.
That's something I'm going to have to go in and think about when I've got everyone's evidence on it. Okay, that might supersede what I was going to ask. I'm not sure, but we'll try it anyway and see how it goes. So this takes us on to question 32. We're nearly there. Yeah, so I asked about if you could get a floor space per 1,000. I just wondered whether that was might be a useful ratio. And you've provided me with one which gives a range of 92 to 148 square meters per 1,000. What it looks like you've done is taken the SFT metrics and divided it by 92%, or multiplied it by 0.92 to derive those figures. Is that right, or is that just a coincidence?
No, that's correct.
Just wondered if that was a valid way of doing it. I mean, because the SFT metric is about the area required per room, whereas what you've given me is an area required per 1,000 population, which is slightly different. It maybe takes you in the same place, but anyway. Because the 0.92, that affects the number of consulting rooms you need, not the amount of ancillary space you need per consulting room. So I just wonder if that was completely two different things, but it's maybe me not quite understanding how those two things come together.
0.92 was based on using the rate per 100,000 and then assuming for each whole time equivalent, if they're 100% clinical, then that's the space for a room. So I guess I'm taking the example, if it's 1 per 1,500, then that's 0.67 of a whole time equivalent that's required, and that would be 0.67 of a room, i.e. 100% of their time is clinical. However, a pharmacist, it's only 25% of the pharmacist's whole time equivalent. When we add those together, that's how you get to the 0.92. So it's working out, it's 1 divided by 1,500 to work out the GP whole time equivalent, 1 divided by 11,000 for the ANP. That gives you your 1.07, and the 0.92 is then they're all 100% with the exception of pharmacy, which is only 25% of their whole time equivalent to get down to the number of rooms. So it's almost one whole time equivalent can equal 1 room with the exception of a pharmacist because they don't need the clinical space all of the time. That's how the 0.92 was worked up.
That's fine. Mr. McLean, if you get any observations on this?
I think it just comes back to the previous discussion about economies of scale and whether it's reasonable. There's a large range there, and we discussed previously whether actually in the case of extending an existing practice with a wide range of ancillary facilities that the higher end of the range is appropriate.
We've covered background already, so that's fine. I was going to say that doesn't seem to have take account of smaller rooms for pharmacists and mental health nurses, but we've talked about that point already, so that's fine. We don't think we need to go into that. And even if you were using smaller rooms, you'd still have the attendant ancillary space. That doesn't go down, so the room that kind of lessens probably the effects of that anyway. Just so in that, can I ask just what size of consulting rooms have been assumed then? Is it the same ones as per the SFT document?
Well, so in terms of the standard schedule was using the 16.5 square metres, which would be the current guidance that we would be driven by in terms of health planning notes. I suppose the point to make that's likely to be bigger than rooms that are already in Meadowbank because it would have been developed at a time when the guidance was suggesting a smaller room.
Yeah, it's 14 to 15 metres was the typical size of the rooms at Meadowbank. I think you said that earlier. that's all the questions that I had for the hearing. But I do want, if there's stuff that you wanted to say, then I want to give you the chance to do that. And as I said at the start, you don't need to necessarily repeat what's in the written evidence, but from NHS Forth Valley's point of view, first of all, is there anything that has not been said yet that you felt was important to say? Okay. Mr. Vivian, you've been able to remain silent for this whole session. Is there anything that having heard that, is there any observations the council wants to make before I give the appellant a chance for the final comments?
Nothing coming to mind, David, unless my colleague Alistair has anything that he wishes to say at this point.
I think maybe the only observation I would make is that there is obvious, and we've been wrestling with this, through dealing with the application, is that the difficulty of defining the facility and being in a position to define that facility when the works, the outline business case and all the investigations need to take place. So inevitably, we're probably going to need to make assumptions. And I think what the council has been trying to work towards with the health board is what are the best assumptions we can make to try and establish what the contribution rate should be. It would be great if we knew exactly what was required. We were at that position, but in practical terms, that's very rarely going to be the case. So we do have to make assumptions. And I think it's finding a basis for those assumptions that's the key thing.
Somebody in the position you're in, I think. Mr. McLean, I don't know whether Mr. Campbell will have anything to say, but I would go and ask Mr. McLean first if there's anything else you want to say.
I think without reiterating old ground, I think it's just we remain of the view, based on all the evidence we've talked about today, that actually the case for why there is a need for expansion as a mitigation for development isn't clear, as distinct from any improvements or expansion that may or may not be needed in terms of the primary care improvement plan. And I think I would just re-emphasise our own reading of the evidence is that isn't supported by the evidence. But I think there's a lack of clarity on how the other NHS services are or are not at capacity in terms of the space. We've had the timetabling information for the practices, but not for the other rooms. And just as an example, in the discussion just now on the ratios to be adopted, and it suggested that there might be other services that weren't captured there. And phlebotomy was highlighted as one. Just actually going back to look at the floor plans, there is a designated room marked on the floor plans for phlebotomy. And so I'm really still struggling to understand where is actually the evidence that the practice is at capacity and what is the mitigation that is needed that is development related.
That's fine as a recap. Mr. Campbell, is there anything you want to add to it before we close?
Only that it's quite telling that this case that the NHS colleagues are advancing does not appear to have convinced the council yet. And we're of the same mind. But that's a general point rather than a specific one. And I would simply adopt what Mr. McLean says.
That's fine. I think I've got what I need. I was going to ask you just a procedural point, Mr. Vivian, just while I've got you here. You recall we had problems yesterday, and I'd given you the chance to think about whether or not you wanted to give me some further evidence on the special housing land audit, because Ms. Devlin couldn't hear. Have you thought about that yet, or is that something you still need to think about?
Yes, I've asked Mr. Devlin to provide me with some comments to form the basis of some further submissions to you.
That's it. And then I can give the appellant the chance to come back on it in due course. Okay. So that's us then. Mr. Campbell and Mr. Vivian, I'll be speaking to you again next week in relation to roads. But for everyone else, I just want to say thank you very much for participating today. It's been very, very helpful to me. So thanks again, and I'll now close the hearing. Thank you very much.
Thank you. We're most grateful. Much obliged.
Thank you.